Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
This week we were joined by Dr. Jenny Seligmann. Dr. Seligmann is a professor of gastrointestinal and translational oncology and honorary consultant in medical oncology at the University of Leeds. We first had the chance to hear Dr. Seligmann at the wonderful Colossus course, which was organized by Dr. Sami Chadi and was held in Toronto back in October of 2024. This was a fabulous 2-day conference on all the hot topics in colorectal cancer. We're looking forward to attending it again in 2026. So in this episode, we really had the chance to sit down with Dr. Seligmann and talk about neoadjuvant chemotherapy for colon cancer. Who did she use it for? Who did the trial use it for? What were some of the results from the FOxTROT trial? There's tons to take away from this conversation. But one of the things that really stood out to us was some of the differences in the structure of the multidisciplinary tumor boards at Dr. Seligmann Center versus many centers in Canada. Perhaps in the future, all colorectal cancers will get discussed at tumor boards in Canada. What do you think? We'd love to hear your thoughts and comments. Please email us at podcast.cjs@gmail.com. Dr. Seligmann, thank you so much for joining us on the Cold Steel podcast. It's an absolute pleasure and an honor to have you on the show. Some of our listeners may have participated in the Colossus course, I guess about a month ago now. That was held in Toronto. That's Dr. Sami Chadi organized, and you were one of the speakers, and the attendees had the chance to hear you speak and just learn from so many of your insights around the treatment for colorectal cancer. So I'm really glad that we could have you on the show and I could have a chance to ask many of my own questions. Maybe we'll just start by asking you a little bit about where you grew up and where you did your training.
So again, thank you for inviting me. A pleasure to be here. And I had a great time in Toronto, I have to say. It was great to come. So I grew up in Edinburgh in Scotland in the UK, and I trained at the University of Aberdeen, which is about 80 miles up the road from Edinburgh. Since then, I've worked around Scotland, say in Glasgow, and for 15 years nearly, I crossed the border into England. And so now I'm based in Leeds, also in the UK.
So the real question is, who do you support from a football perspective?
Oh, there you go. So it would have to be Hibernian, a lesser known Edinburgh team. I would say field hockey, not ice hockey. I saw some ice hockey in Canada. That's way over what I would be involved in. It's more my sport. But if you push me, Hibernian, certainly not Leeds United.
Makes sense.
Certainly not Manchester.
Oh dear. Oh boy. So, obviously research has become such a big part of your life. Was that something that was always on your radar, or was that something that kind of came about organically? Can you tell us a little bit about your journey towards research?
Yeah, no, please too, because I think that there are some people that are on a very clear track from the start. Say they may have done a research degree before going into medicine. I wasn't on that track. I started medical school when I was 18, was a doctor at 22 and was just trying to survive. But then I found my way into oncology and into a very supportive department. And in the UK, we actually have posts where you do your training, you can spend a proportion of your time doing research, which then gives you enough papers and I suppose output to then be able to do a PhD. So come out of being a doctor for 3 years and do a PhD. And so that's what's happened to me. I'd done bits and bobs throughout my training. I was always quite interested and quite motivated, but I certainly didn't start out thinking I would like to be a university professor rather than a full-time doctor. But I was very fortunate. I had a very good environment. I had a very good research team. The team in Leeds is very well known for bowel cancer research. And I think that's critical to the success. So we have Phil Quirk, who's a very well-known pathologist. I've David Jane, a well-known surgeon. We've got Matt Seymour, who was my direct supervisor. And so it was a really good environment. And I think the environment then, and of course, the specialties working together, you get so much more than anybody working themselves. And so after the PhD, there was just opportunity after opportunity. So I was really quite fortunate, but the funding is in place in the UK. And I think it's a bit easier than I think it may be in other places in the world, actually.
don't think I appreciated what an amazing kind of environment you work in and the team that you have. How did this sort of setup develop, and what makes Leeds so special in terms of being able to put out some like really world class? I think, is it Professor Morton as well?
So Professor Morton is in Birmingham, but particularly Matt Seymour and Dion Morton worked together for years. I feel I stand on the shoulder of giants in a way, but the real success was, so Matt Seymour as an oncologist had clinical trial samples. We had Bill Quirk across the corridor who had a laboratory and was leading in pathology. And so actually the combination of the two really then drove a lot of the research, and more so than just looking at one trial, it then allowed the next phase of trials to be developed from the translational outputs from the trials that had been done. Similarly, I think those of us who have been able to have some academic success have been able to support people in other disciplines. We've been able to support our radiologists, and now I think leading the world in localized colon cancer and radiological staging. So lift as you climb, I think, is the moral of the story there.
I love that. That's a great phrase, lift as you climb. And clearly there's the energies of a small-ish group of people. It kind of creates this culture where people are able to do stuff. You don't need necessarily, it sounds like, a whole bunch of people, but just a few people, the right people in the same spot. There's some synergy there.
And it's just making the opportunities. So, we don't have the same kind of laboratory facilities as Cambridge does. But then you think about what you can do in your own institution, and we have clinical researchers, but then we collaborate. So we collaborate across the UK, we collaborate in France, we collaborate with anyone really. But the next set of FOxTROT trials were mainly designed initially in the station in Birmingham, where me and Matt Seymour and Dion Morton got together because it was the easiest place to meet, and spent 2 hours thrashing through what we should be doing. And so it's making opportunities, and a lot of people who have come along since and are involved just because they got in touch with us and said, could we be involved? And mainly we can involve people. So
I don't think I appreciated as a trainee how small the world really is. There's just a few degrees of separation, really, if you're interested in certain topics. That segues really nicely into talking about the FOxTROT trial. I think if you're a colorectal surgeon, you've heard of this trial. If you're an oncologist that deals with GI cancer, you've heard of this trial. It's really a landmark sort of trial. Tell us a little bit about the genesis for this trial, and where did you sort of come to this idea?
I'm going to give credit where credit is due, and the credit really needs to be given to Dion Morton and Matt Seymour, because they were really the people who were there at the very start. I suppose what we were seeing in other tumor types is it was at the point that FOxTROT was being developed, this was coming along in other tumor types. So neoadjuvant treatment was starting to become standard of care in ovarian cancer, for example. And so the rectal cancer story was slowly, I feel the rectal cancer neoadjuvant space took 20 years really to filter through. And so the premise was the same. So can you deliver part of your chemotherapy before surgery? And of course, it's not just to downstage tumours to increase the R0. In my mind, actually, the biggest benefits is treating micrometastatic disease. So what you can't see early. And number two, getting chemotherapy into people. Because again, as an oncologist, you often meet people after they've had an operation, and they've had a further insult of an operation on top of what they were normally like. And it's quite difficult sometimes to deliver chemotherapy, particularly in older or patients with comorbidities. So the whole hypothesis was, for all of these reasons, could you get better outcomes? And when I say better outcomes, I don't really just mean surgical outcomes, I mean survival outcomes, because really, ultimately, that's what's most important. And Dion's view is that a lot of it is oncocare. So he's very pleased that he sends off a patient for 6 weeks, 12 weeks, to a physician. So we'll sort out their anemia and their diabetes. So there's multiple factors that can play. You balance that because, of course, when we started FOxTROT, it was quite a hard sell. People were worried that tumours were going to obstruct People were worried that the toxicity of chemotherapy would mean that operative outcomes were compromised. And actually in FOxTROT, we didn't see that. And actually none of the neoadjuvant trials, the one thing that's completely consistent about all of the trials is that surgery, in fact, isn't compromised. And in fact, in FOxTROT, there were fewer surgical complications than in the straight to surgery arms. So that was the hypothesis, and I suppose some of what we found.
It's really a really big shift in paradigm, I think, for especially if you're a surgeon and you think, oh man, this is something I can cut out, let me cut it out. But I think if you take a step back and just ask yourself if how does the patient do ultimately? The operation may have went well, but how does the patient ultimately do? I think that's then you start to ask different questions like that your group did. So for anyone who hasn't done a deep dive on the paper, who knows the exact results of the paper and the methods of the paper, can you talk to us a little bit about exactly what were the different groups in the paper, and what were your inclusion and exclusion criteria?
Sure. So the inclusion and exclusion criteria were meant to be quite broad. As you know, in the UK, what we enjoy doing is very pragmatic trials. So the trial was recruited across 80 centres in the UK and then 20 centres in Sweden and Denmark. And essentially, the biggest change is that we were recruiting patients based upon radiological stage. So usually the decision for giving chemotherapy is based upon post-op pathology. But actually, similarly to rectal cancer, we were basing the inclusion criteria on the CT. So patients had to have a T3, T4 with any nodes, so N0, 1 or 2 included, and were felt to be fit and were not obstructed. So that was the inclusion criteria at the time, remembering that FOxTROT started recruiting in 2011, so really quite a long time ago. And it was meant to be broad. The thing that we did at the start, and even now, is that we had to do training of all of our radiologists to make sure they were able to interpret the CT scan. So what would we judge to be T3, what would be judged to be T4? So any centre that participated in the trial, the radiologists all had to be trained to do this, because many radiologists even now really don't like calling staging on primary tumours in colon cancer. So that was the main criteria, and it had to be colon cancer. So rectal cancer wasn't included.
And just to be clear, so these patients were receiving what chemotherapy and for how long?
So standard chemotherapy. So the trial, all the trial was, it's really not a very complicated trial. So all patients had 24 weeks of chemotherapy, but in the experimental arm, 6 weeks of that was moved ahead of surgery. So the same chemotherapy, so oxaliplatin and 5-FU. So exactly, completely standard chemotherapy. The only intervention in the trial was giving 6 weeks of that ahead of surgery.
Most of the people who listen to this podcast are surgeons or surgical trainees. Can you explain the subtype specifically for RAS wild type tumors?
Well, actually, so in locally advanced colon cancer, RAS isn't much of a thing yet. I say yet. I'm hoping to change that. At the point that we started the trial, we didn't know about things like mismatch repair and the impact of mismatch repair. But again, because we had Phil Quirk, who I discussed earlier, was a pathologist and understood very early the mismatch repair, we collected all the tumor blocks and we had our mismatch repair data absolutely ready to go when we reported the trial. And actually, in the trial, we saw exactly what we expected, was that patients with deficient mismatch repair, so MSI high tumours, in effect, didn't benefit from neoadjuvant chemotherapy at all. So that's the most important subgroup. So as I discussed in Toronto, increasingly and now deficient mismatch repair and proficient mismatch repair just really need to be treated completely separately. So we've seen the results from the Niche 2 trial. So that was the neoadjuvant immunotherapy trial in deficient mismatch repair tumours. And they saw pathological complete response rate of nearly in 2/3 of patients. and no patients having any disease recurrence at 3 years. So the deficient mismatch repairs, they're the group that should have immunotherapy. The proficient mismatch repair, which is about 80% of tumours, were the ones that benefited from neoadjuvant chemotherapy in FOxTROT. So two totally different groups. RAS, RAF, we don't test those routinely. I think we will in the next 5 to 10 years, but in the locally advanced setting, it's not relevant.
That totally makes sense. And it's important for readers to remember that like a trial like this takes obviously years to recruit. You said you started in 2011. So obviously our understanding of colon cancer and rectal cancer has changed significantly in that period of time. Can you talk a little bit about some of the challenges of running a trial like this before we talk about the results? I mean, one thing you talked about is the radiological assessment. And I suspect radiologists around the world would have this challenge. Did you get the sense that radiologists could have given you a staging but just didn't want to? Or was that something you really had to work with radiologists a lot to kind of standardize and make sure that you were getting an accurate assessment?
So within FOxTROT, I suppose it was less of an issue because the centres that signed up, the radiologists signed up as well. So essentially the key to the success of FOxTROT and some of the difficulties of FOxTROT I can come into is that it's a multidisciplinary trial. So it's not locally advanced colon cancer isn't a surgical trial, or it's not a chemotherapy trial. It was a trial of an MDT and a patient pathway. So for FOxTROT, actually getting the radiologists on board was actually relatively easy. The training was done by Gina Brown, who's a very well-known radiologist from London. And the question, the difficulty that you have is people often say, well, a proportion of the patients that went straight to surgery who were recruited into FOxTROT would never have had chemotherapy because their tumour was overstaged, for example. And so you were treating a bunch of people that maybe didn't need chemotherapy. And that I think that's been the main criticism of FOxTROT, is that there's the risk of treating low-risk tumours. I think you need to turn that on its head somewhat, because like in rectal cancer, we've got away from that. We're not trying to compare the MRI to the surgical resection specimen anymore. We've moved on. We've understood that actually what you see on the MRI has prognostic implications. So what's high risk on an MRI is actually high risk. It might not correspond with the pathology, but it's high risk. And actually a lot of the work we're doing in FOxTROT is trying to understand how you identify the high risk patient at the very start. So we've produced some data, and you'll see a paper soon that is saying, well, if the nodes are over 10 millimeters, then that's likely to be a positive node. You can't just use the normal criteria. But to get back to your original question, getting radiologists across the world to change what they do absolutely is a challenge. However, it's getting to the point that it's not acceptable to just say, oh, I don't do that. Because certainly in the NCCN guidelines, they've just recommended neoadjuvant immunotherapy for T4BNX tumours. So actually, the neoadjuvant immunotherapy is moving along just the whole neoadjuvant chemotherapy. So it is getting to the point that the radiologists are starting to understand the significance, whereas previously all the radiologists had to do was METs, no METs, because patients were just going to surgery. So this is the clinical need is changing, and our experience is that radiologists across the world are actually looking for the training, which we are providing. And actually, perhaps I could send you a link to some of our radiological training resources, because it's more than just chemotherapy, it's immunotherapy now. So fingers crossed.
Yeah, that would be great. And, typical surgeon, I'm picking on other specialties and not really asking questions about my own. I think probably the biggest barriers to recruiting to a trial like this would be convincing surgeons that, to offer someone chemotherapy in a state or in a situation where I feel like I could surgically remove something. Was that a hard sell for you to like, it sounds like people came and wanted to be part of this trial, so perhaps this wasn't a barrier, but was it hard to get surgeons to buy in and commit to a trial like this?
somewhat of the difficulty of FOxTROT 1 was that patients could either go and have an operation right away or be randomized to chemotherapy. So it was quite tricky to balance that in a way, because surgeons, if they gave a patient an operation date and then said, oh, well, we've got this trial, patients would tend to go for the operation date. But I have to say, in defense of your specialty, if you go through the data with surgeons tend to be quite pragmatic about it. So long as we're clear in explaining why we're giving the chemotherapy. I think if the surgeons think that we're just giving the chemotherapy to achieve an R0 resection, which we're not, it's different from rectal cancer in a way, then they've tended to be quite receptive. It also takes a bit of pressure off your theatre lists. So if you know that actually this patient coming through doesn't need to go for an operation for 3 months, then that's quite a bit easier than trying to schedule them in the next couple of weeks. But again, it depends. So some countries have multidisciplinary teams where all patients are discussed. So in the UK, all colon cancer patients are discussed at diagnosis, whereas I know in other countries, patients are only discussed at a multidisciplinary team after they've had an operation. So delivering this requires the same kind of fundamental change in the pathway that was done for rectal cancer. So that can be challenging.
Well, I want to talk a little bit about the results. Your primary outcome was residual or recurrent disease within 2 years from random assignment. Can you tell us a little bit about what you found in terms of that primary outcome and some of the other secondary outcomes? I think in particular, the toxicity component to it, I think, because I'm sure many folks were concerned about the toxicity profile.
Yeah. So the predefined primary outcome was anyone who had residual disease. So say a patient's had an R2 resection, that would be considered an event, or had relapsed or died within 2 years. And we can talk about whether that was the right time point. And what we found was patients treated with neoadjuvant chemotherapy had fewer events than the patients who went straight to surgery in terms of their longer term cancer outcomes. So what was behind that? So number one, fewer rates of micrometastatic disease, considerably more chemotherapy given in the experimental arm. So patients were more likely to ever have chemotherapy. So we recruited some patients in the control arm who went to surgery and then didn't get chemotherapy because they weren't fit. So I think that nicely illustrates the point we made earlier about meeting these patients in the clinic. And in the adjuvant chemotherapy trials, we don't know them because they're all fit for treatment. So it was kind of proved the point that we knew instinctively that would be the case. So we saw downstaging of tumours, we saw downstaging of nodes. We saw differences in outcome by mismatch repair status, exactly as we expected. So really the most relevant result is in the proficient mismatch repair MSS group, where we saw an even bigger advantage. We also saw that some groups benefited more. So we've talked about the proficient mismatch repair. So T4 tumours had a greater benefit, which again isn't hugely surprising. So radiologically staged T4 tumours really had a big benefit from neoadjuvant chemotherapy. So if someone was going to take something away today, do I want a group that I want to prioritise for neoadjuvant chemotherapy? For me, that's your T4 MSS tumours. They're the group that, despite an R0 resection, are likely to come back with metastatic disease in the future. In terms of toxicity, so the chemotherapy toxicity was not different between the two arms. Patients weren't more likely to have toxicity. The surgical outcomes in FOxTROT were a bit better in terms of not just the R0 resection rate. Now, our pathologists had an extremely stringent criteria, so more so than I would say normal standard of care in assessing something to be R1, because a lot of people have said, well, actually your R1, R2 rate was actually quite high. Our pathologists were behind that. But again, both samples, both sides of the trial were considered the same by the same people, and we did see less incomplete surgical resections. The other thing as surgeons that you're interested in is, well, did these people obstruct? And the answer is not that many. And I think the rate of obstruction was 2 to 3%. And it wasn't hugely different than what we saw in the control arm. So that between randomization and an operation, it wasn't different. And the risk factors for patients who would have had an obstruction was mainly, you won't be surprised, tumours at the flexures. They were the ones that were most at risk. So people who I'm concerned about when I sit in my own tumour board and I'm going to give particularly neoadjuvant immunotherapy, the things I get a bit twitchy about is tumours at the flexures and impassable through a scope. Impassable through a scope by itself with no other obstructive features wasn't particularly at risk of developing obstructures, but that plus a flexure. So, for example, if we're going to give particularly 3 months treatment, we'd usually defunction those patients if they had a big T4 tumour. That's usually what we would do. So the results in terms of the toxicity, pretty much the same in the big other trial. So the optical trial was another neoadjuvant trial, and that showed very similar, consistent results in terms of toxicity and the primary outcome as well.
Yeah, it's really an amazing trial. I want to ask you how this plays out in your own clinical practice. How do you select now patients for neoadjuvant chemotherapy or perhaps even immunotherapy? Are you using the same criteria from the FOxTROT trial, or have your indications evolved, especially now that you know more about MMR status and things like that?
So in terms of the radiological staging, anyone with a T4 tumour, certainly in our tumour board, would be considered for neoadjuvant treatment and sometimes defunctioning if it looks like a nasty tumour in a young patient. And we would want a radiologist to be really definite when they were calling a T3 tumour in particular. We wouldn't treat tumours that were just T3. We'd want a definite T3 as called by our radiologists. And we would always know the mismatch repair status before we started any neoadjuvant treatment. In the UK, certainly, we can access neoadjuvant immunotherapy if they have an unresectable tumour. So we can give them neoadjuvant pembro and probably soon nivo-ipi. If they have a MSS tumour, we'll give them chemotherapy, but we will do that in the context of our next clinical trial, which is FOxTROT2, FOxTROT3 and FOxTROT4, which is all looking at different neoadjuvant approaches. So patients will, as much as possible, go into a clinical trial. And we have a couple of clinical trials for neoadjuvant immunotherapy as well. Again, the AZURE-2 trial is a global trial looking at neoadjuvant PD-1 dostarlimab, which is the drug that they'd used so successfully in rectal cancer. So hopefully that can become standard of care over the next 5 years or so.
Yeah, that's fantastic. One of the things I wanted to ask you about, and we chatted about this a little bit when you were in Toronto, is the way that your multidisciplinary tumor board meetings are structured and how they happen. Because I think that's very germane to how folks listening to this think about rolling out something like what your group already does. Can you talk to us a little bit about the structure of your tumor boards?
Yeah, of course. So our tumour boards include everybody that you would imagine would be in a tumour board. So there's representatives from surgery, of course. And of course, there's different types of surgeons within the lower GI space. So there's people with different interests. In our own centre, we do quite a lot of pelvic exenterations for regionally. So there's quite an interest in that. We have medical and clinical oncologists. So that's chemotherapy doctors and radiotherapy doctors. We have radiologists, pathologists and nurse specialists as well. I think one thing that might be a bit unusual about our MDT is that we have very active radiologists, I would say. So the radiologists will often kind of call what kind of comes next based upon their report, both in colon and in rectal cancer. So they'll give their opinion of if this patient would be suitable for neoadjuvant treatment. So they'll almost finish that sentence. And what we've discovered is sites that have recruited well into the FOxTROT and the neoadjuvant immunotherapy trial, the thing that they have in common tends to be active radiologists that are kind of really participating in the discussion and a tumour board that really values their role. And we do, because all of neoadjuvant chemo treatments are based upon the call, essentially, of the radiologist. It requires relatively rapid mismatch repair or MSI testing. And again, that's something that our pathologists and our tumour board have worked hard to do. But I think the biggest difference, I would say, between our tumour board and some other ones is that we do discuss colon cancers before they have surgery. And I know that's not something that's universal and something that would need to change for people to deliver neoadjuvant treatments.
Yeah, I think that is it is a fundamental difference. Certainly at our own institution, we're not bringing to the tumor board every resectable colon cancer for a variety of reasons. One of them being limitations of our clinicians to be a part of a longish or longer tumor board discussion. But obviously, we may have to change that in the future. I love this idea that the radiologists are invested in the treatment for the patient, because I know here, if someone's seen in the emergency department and the radiologist writes, general surgical consultation is required. But that's what happens. The general surgery gets consulted.
It's on the radiology report, so therefore it's gospel.
So it's got to happen, right? So it is true that like something like that can really drive change and make a difference. And I also, just as a commentary, you see how research now is feeding into clinical practice and vice versa, right? Your group has done such a fabulous job recruiting to this trial that it's now changed clinical practice and the way that people function. And so I think that's a powerful impetus to conduct clinical research and to be a part of it, because it really does drive and raise the bar for how people practice. Obviously your group is still so active. You mentioned a few of the other trials that you're working on. Can you tell us a little bit about what's next on the horizon, what these other trials are looking at and are recruiting for?
We have basically a platform trial looking at neoadjuvant strategies, and it's open in 50 centres in the UK and in France, soon to be Italy and India. We did try to persuade some Canadian oncologists to take part, but I think there's some competing trials in the ctDNA space. But maybe you as a surgical group can go and promote it. So FOxTROT 2. So essentially, what we want to do is we want to have a good option, a good neoadjuvant option for any locally advanced colon cancer. So in FOxTROT 2, we're looking at older patients because we think they're particularly underserved. I mean, median age is 71. We know this, less likely ever to get any treatment in the adjuvant setting. So we think that the older patients may actually gain the most from this approach. We've got FOxTROT 3, which is looking at intensified chemotherapy. So FOLFOXIRI, I think you've encountered all in the PRODIGE rectal cancer trials. So in FOLFOXIRI, and that's been the only chemotherapy that's been shown to have an overall survival advantage in rectal cancer. So we're testing it in colon cancer. FOxTROT 4 is quite cool. So FOxTROT 4, going back to our point about BRAF and RAS. So BRAF mutant tumours, I'm sure you all know they're the bad group. So they're the ones that drive the poor overall survival. They're often mucinous. They come back with peritoneal disease, nasty tumours. So in the metastatic setting, we treat those with a targeted approach. And you often see really amazing downstaging and shrinkage. So in FOxTROT 4, we're trying to find these patients. It's only about 6% of the MSS population, so they're not easy to find, but we're testing them for the first time in the world ever with neoadjuvant encorafenib and cetuximab, and we've found 8 of them so far, which is great. We need to find 30. And then that's our MSS platform. We've then got FOxTROT 5 and FOxTROT 6, which is in the MSI high group with dostarlimab working with GSK. So we're doing 2 things, looking at dostarlimab in older patients, because again, mismatch of MSI high tumours tend to be older patients. And then we're doing something really cool in FOxTROT 6 that might get some surgical antibodies going, is that we're looking at giving 6 months PD-1, so immunotherapy, to the MSI high tumours. We're expecting most of them to respond. And then we're going to try and not operate on them. So wish us luck. What we're trying to do is we're trying to devise a protocol. So we're trying to devise a standard protocol, because a lot of people are doing this in trials and they haven't really used a standard surveillance or radiological or endoscopic criteria. So we thought, we will try and do this. We'll see how we go. Put you out of a job.
I love it. I would be happy not to. I'm sure I'll be able to continue operating on hemorrhoids, so it'll be fine. I'm sure I'll continue to have a job there. Um, you know, it's amazing the work that you and your group have done, and I'm curious if you have advice for folks who want to be clinician scientists. How do you balance that type of practice, and what advice do you have if you want to be a successful clinician scientist?
You need to be in a good group. You need to have good people around you. You can't do anything entirely by yourself. You need to have an idea. It needs to be a good idea. You need to have lots of things that back up why you want to do what you want to do. And then when you're convinced that you've got a good idea and you're on the right track, you really have to be pretty relentless. You have to believe in what you're doing. You have to accept that not everyone else is going to believe in what you're doing. And you need to listen to why they don't believe that, and modify where you can. But when you believe in it, you need to keep to your track, and the data will show itself. I would say when you're starting in your career, it's good not to put all your eggs in one basket. So I've got the FOxTROT trial, but I also run another trial in metastatic colorectal cancer. And you just need to keep seeing patients, keep understanding what you do is relevant, keep being productive, keep collaborating, accept that you can't do everything yourself. So going back to lift as you climb, the best papers with my name on them over the past year have all been written by my PhD fellows. So this is really important. And speak to people in other countries, because again, I was very blinded by what happened in the UK in terms of our MDT practice. So when we tried to launch FOxTROT in France, I had no idea that their radiologists didn't radiologically stage colon cancer. And so you have to understand not only the environment in your own country, but the environment across the world, because ultimately you want to deliver research which is going to lead to world-changing practice, rather than just changing practice across some sites in your own country. So yeah, be bold.
I love it. You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.